Dr. Pooboni.
Thanks, Pranay. Thanks for accommodating me. Currently, I came to UK. Uh, I would like good evening, everyone. I would like to discuss the very important aspects regarding the history of technology and equipment development for a ECMO. This has happened over a period of decades to centuries. It is very important for us to understand this so that we know how much our predecessors have struggled to reach this point. I will very briefly mention about the history of clinical trials of ECMO and history of our organizations such as ECMO Society of India, SWAC ELSO and ELSO, and very briefly also about ECMO ELSO statistics. So, ECMO is such a big tree as you are seeing there with deep roots for foundation, and from there it has developed and branched so much, and it is still branching now. So this is a huge subject for all of us to learn and keep learning again and again. By this time we all know ECMO is nothing but it is a technique of supporting heart and lungs for days to weeks whenever there is a heart or lung dysfunction that is not amenable to maximal conventional management in the intensive care setting. These initial ideas have started in the years around 1700 or 1635 to 1700. Around that time, Robert Hooke he conceptualized the possibility of oxygenating blood um, and then sending it to the body once again. Maybe this sort of mechanism will help uh, a person to be alive for long periods of time. This is the initial concept, and from there lots of people have worked, scientists and physiologists. They worked on methodology of oxygenating the blood by shaking it with initially as a defibrinated blood when heparin is not available, and once heparin is available they continued their experiments with the blood. But the initial pictures till 1882, Van Stroder, Frey, and Gruber, till that time, they have been experimenting with the animals with the concept of oxygenating blood by shaking it together with the defibrinated blood in a balloon or in a glass apparatus so that the oxygenation content of the plasma has gone up in those cases. In 1916, heparin was invented by Dr. J. McLean when he was a third year medical student. And from then onwards, in the next 2 decades, further improvement in the technology of heparin by purifying it and making it possible for human use by Dr. Charles Best, the inventor of insulin in Toronto, that has made to the commercial use of heparin, and that helped further in using heparin for preventing the clotting of the blood, etc. So this is another era. And the era before 1916 is on experimental animals and on defibrinated blood, and after 1930s, whole body perfusion of blood in a dog initially by Brukshenko in Russia, but afterwards the was the birth of cardiopulmonary bypass as it has all started in human experiments or human surgeries. So this is the picture of Brukshenko and the development of first heart lung mission for total body perfusion. McLean, as a second year medical student, he discovered heparin. It is worth reading about J. McLean from the Wikipedia, and from the internet. You will get the information as well, like, like how hard they worked to study medicine and develop these things. In 1930s, John Gibbon he began investigating the use of extracorporeal membrane oxygenation. Dr. Gibbon was surgical fellow at John Hopkins at the time, and he was looking after a patient post pulmonary embolectomy. Unfortunately, the patient expired the subsequent day, but his thought process is about building up an apparatus where we could bypass the blood through an oxygenator sort of mechanism till the lung function recovers. That led him to work for the next 30 years in building up an apparatus and coming up with open heart surgery as he stood the founder father of cardiothoracic surgery. So the open heart surgery became possible after Dr. Gibbon's experiments. So this is John Gibbon and Mary Gibbon, who was his technician initially. Later, they got married and they continued their work. In 1953, and Dr. Gibbon he operated on a girl with atrial septal defect, and it was a success story. This was Cecilia, on whom he operated. Her picture 10 years after the surgery. Then Dr. Gibbon lost his next three patients on this mission. So he felt disappointed. He thought this mission is not for human use and he abandoned the mission. Then Mayo Clinic asked for the plans of Dr. Gibbon's oxygenator, which he shared. They developed a Mayo Gibbon type of oxygenator, and for the next several years, they used this device on hundreds of patients. The mortality rate for intracardiac surgery dropped from 50% in 1955 to 20% in 56 the subsequent year and 10% in 1957. So you can see how remarkably this apparatus has helped in saving the lives of the patients following cardiopulmonary bypass. These are remarkable researchers, cardiothoracic surgeons of the day. Dr. Lilly, he performed cardiac surgery via cross circulation using a bubble oxygenator he invented along with Richard Dewall here. The parents used to serve as the donors for the cross circulation. So this mechanism didn't find a good favor the subsequent years as there were better technologies. But there was an era where he performed cardiac surgery, open cardiac surgery via cross circulation. Next era belonged to the development of the oxygenators further making better models. How can make this gas exchange possible with the development of the bubble oxygenator, silicon rubber oxygenator, and later on polymethyl pentyl oxygenators, and the current oxygenator which we are using now. In the 1960s, prolonged bypass days to hours to were possible in animal experiments. Bubble experiment was one of the bubble oxygenator was one of the initial oxygenators. The difficulty with this was as lots and lots of air was pumped or oxygen was pumped into the blood, then there were bubbles generating within, more of coagulopathy, hemolysis, and the patients manifested edema, low platelet count, and organ failure as well. So this was attributable to blood gas interface. At the time of uh, Colombo and Zapal in 1968, they built a silicon membrane oxygenator, which was a better device compared to the bubble oxygenator. There is no gas are lost here. It worked for weeks to months and limited by diffusion of the oxygen through the blood. When I started my ECMO practice, yes, in those days we used silicon membrane oxygenators in 1990s. Semi-porous hollow fiber oxygenators came as the next generation. Here, gas flows through the fibers. Scientists have experimented by gas flowing through the fibers or outside the fibers, but they felt the mechanism is better when gas is flowing through the fibers and blood outside. So, in these hollow fiber oxygenators, the deficiency was development of plasma leak across the fibers, and increased secondary flow was also noticed in that. We're seeing the current generation of membrane oxygenators. They are for good long-term use, lead platelet aggregation and minimal hemolysis with hollow propylene fiber material, and it is the current gold standard for us. Small, compact designs with maximal surface area. That is about the development of the oxygenators. Then, clinical use point of view, from the literature, we can see Dr. Donald Hill was the first person who put an adult patient on ECMO for 75 hours outside the cardiac theater in 1972. The patient sustained a road traffic accident and he had a rupture of the aorta, which was repaired at the time. For 72 hours, he was on ECMO. Please notice the size of the oxygenator, which is just adjacent to the bed of the patient, how big it was. It was almost the size of half of the cot by itself. Simultaneously, Dr. Bartlett was also operating, uh, and uh, he used ECMO on a 2-year-old boy in 1972 for doing mustard procedure as a open cardiopulmonary bypass technology. And then the history started once again in 1975 when Bob put the first patient, Esperanza, on ECMO. This is baby Esperanza. Her mother was an illegal immigrant from South America. So she came and she delivered in the hospital where Bob was working. She had severe meconium aspiration syndrome. All possible conventional ventilatory strategies available in those days has failed, and the only way left was ECMO. So Bob put this first patient on ECMO at that time with the consent of the mother, and she survived. So it made a history after that, and she was labeled as she was named as Esperanza by the nurses. Esperanza in Spanish means hope. So this girl remained as a hope for the entire ECMO community. These are further photos of Esperanza when she was 21 years old and 46 years old also in 2019. Whenever we go to US for our conferences, sometimes Esperanza comes and meets us. Then was the development of WMN oxygenator. Schwiesberger, he played a major role in that, in the development of a WMN single cannula, which revolutionized the technology of ECMO. So whenever it is available, certainly this is the best way so far. Though further generations of more sophisticated cannula are being experimented as we speak. Bob Bartlett in 1989 established the organization of ELSO, which stands for Extracorporeal Life Support Organization. So, all these clinicians who have been practicing in ECMO assembled at one place in Ann Arbor, Michigan in 1989 and exchanged ideas. Since then, it has become an annual conference anywhere in US, and sometimes it comes back to Ann Arbor, Michigan. Our 25th anniversary, the Silver Jubilee anniversary was in Ann Arbor, Michigan once again. So this is the place where ELSO originated. This is a circuit diagram for ELSO. ECMO, sorry, ECMO circuit, two oxygenators for bigger patients in those days. And this picture is from 1999. You can see a baby on ECMO over there. And we were using a roller pump ECMO in those days. So you can see the ECMO console, oxygenators over there, um, ventilator to a side here, and this child was on CRRT also. How does ECMO work? It is like a broken leg analogy. When a leg breaks, you don't want to start using it once again. You would like to give rest to the leg. So similarly, when we exhaust the capacity of the lungs are hot, then we tend to give rest to them so that we can start working with them once the repair process is over. So to prevent barotrauma and value trauma happening, we go on to ECMO, and certainly we have been seeing that ECMO works in a proportionate cases in different age groups. Regarding the trials, in 1970s, NIH trial was the first trial in US. It was a national multicentric trial, but at that time, the criteria was not very well established as this was the first multicentric trial. Majority of the centers participating in this trial were novice. They haven't done ECMO before and they were doing ECMO for the first time. There were no set guidelines for anticoagulation. Blood loss was huge to the tune of 2 liters uh, also in those patients. So no wonder conventional as well as ECMO group death rate was near 90%. This was taken as a failure study. The problems were there was no prior experience of ECMO in these centers. Best and worst patients were excluded. It was a time of influenza epidemic and bleeding was more than 2 liters per day. Lung rest was not used at all. People felt that that's the death of ECMO, but it didn't continue like that. Few of the investigators and clinicians, such as Robert Bartlett, continued to have ECMO, interest in ECMO, and confidence in ECMO, and continued to put babies in ECMO. They have got much better results, 50%, 80% survival rates. So by 1980s, Bob was doing a few cases per month, and other centers also picked up. In by 86, 18 centers in USA were doing neonatal ECMO, and they did another trial, and this time particularly on the neonates only. They treated 45 neonates with a success rate of over 50% in this. So by 1986, 750 neonates were put on ECMO with a overall success rate of more than 80%. So this was a vast improvement compared to the previous mortality rate of 90% or previous success rate of 50%. Then the Boston Children's Hospital's trial was the next one. Here, 19 patients with PPHN were randomized to ECMO limb versus conventional limb, and ECMO limb had a much better survival rate. In United Kingdom, there was a need for a randomized control trial to make sure whoever are put on ECMO are being paid by the National Health Service. So for that reason, and there was a trial started in ECMO uh, based at Glenfield Hospital as a center, along with three other hospitals also in Glasgow, in London, Great Ormond Street Hospital. Also, these were the centers at the time. So, in 185 children, they were randomized between two trials, like 93 to the conventional, 92 to the conventional limb, and 93 to the ECMO limb. Here, 63 children survived to 1 year of age, and in the conventional limb, only 37 survived to 1 year. So, this was proven as a much better study compared to the previous one, because the last study we have seen in USA was only 19 patients. Here, 185 patients with that. This has got a better implications, better survival rate also in this. This study was very well followed up further at 1 year follow up, 2 years follow up, 5 year follow up, like that. Further follow up was also done. So Richard Farmin was the person who took ECMO to Leicester in United Kingdom, where I worked for a couple of decades. That was the first center in Europe to start ECMO, and they had belief in doing ECMO, so they put adult patients also on ECMO at the time, and these are the survivors of ECMO. And in the middle, you see one dedicated surgeon with the goggles. He was Andrew Sosnowski. He was a contemporary and a colleague of Dr. Richard Foreman. Both of them, they looked after 24/7 care for nearly 20 years. ECMO's organization data in it changes in neonatal versus pediatric versus adult centers. Here the outcomes are mentioned. Neonatal respiratory outcomes are 77%, cardiac outcomes are 38%. You can see more or less neonatal, pediatric, and adult cardiac ECMO outcomes are in the 30s to low 40 range only. Whereas neonatal respiratory outcomes are better, followed by pediatric respiratory outcomes and adult respiratory outcomes. Bob Bartlett calls the period after 2005 as ECMO 2. This is because centrifugal pumps, PMP oxygenators, that is polymethylpentane oxygenators, proning, physiotherapy, and further innovations for the biocompatible equipment became available at this time. So this is completely different to what we were doing before on roller pump ECMO. Bob calls this as a ECMO 2. Then we started doing Caesar trial in United Kingdom with the basis of Glenfield Hospital as the ECMO center. So Glenfield Hospital was the only ECMO center looking after these trial patients of Caesar, while there were nearly 90 centers in sending patients to ECMO from various adult ICUs in UK. So in this 57 patients on ECMO, they improved in the ECMO limb. In the conventional limb, 47%. Let us talk about the percentages. In the conventional limb, 47% was the success rate, while ECMO limb 63% was the survival rate. There is some criticism about this Caesar trial. Like people said, those cases which didn't go on to ECMO but still managed on ECMO principles were taken as positive outcome patients for ECMO. So there was some criticism about this. To amend this criticism, ELIO trial was done by Dr. Alan Coombs in France. Very meticulous study, but they didn't wait till the end of the study, as the success rate was um, becoming more obvious. But those cases who were dying also were put back onto ECMO limb. Here, ECMO has got more success rate, but not to the same statistical significance the researchers expected. So this we do feel as a positive study. So the technological improvements have made ECMO easy after that, easy to prime circuits within 10 minutes, and cannula implantation through Seldinger method. Pump is also easy to use. And another characteristic features of ECMO 2 period are low resistance lungs, can be used with low pressure safe pumps which are less thrombogenic. Self-regulating circuit needs only a flow switch and easy operability. Physiology will teach itself like that. At least one nurse can look after two patients. It has changed to the period where in the ECMO 1 period we were using two nurses for every ECMO patient. We were using two nurses. So, moving on further, reviewing the history, first adult patient on ECMO was in 72, first neonatal respiratory ECMO was in 75, then trials were conducted in US and the United Kingdom. Caesar trial, H1N1 became a pandemic in 2009 to 2010. Bulio trial after that. COVID pandemic came in 2020 to 2021. Some of the continents, such as Australia, who weren't following and practicing ECMO widely before influenza epidemic, that is before 2010, started practicing ECMO more and more after influenza epidemic and certainly during the COVID epidemic. Then in wealthy countries such as United States, people have gone forward for artificial lungs as well for supporting ECMO further. So about ELSO, ELSO remained our central organization by imparting knowledge as well as practices control over ECMO practicing centers all over the world. In 2012 point of time, Bob Bartlett and a team, they thought about spreading ECMO to the rest of the parts of the world. So other ECMO chapters have been established at the time. Ours is Southwest Asia and Africa chapter called the SWAC chapter of ELSO. We're all subchapters, one of the four subchapters of ECMO, ELSO. So the center map has gone significantly. There was only one center in the region of India, and even in this Asia also. But now the number of centers have gone significantly. Overall patient outcomes, like the slide I have shown you before, adults, pediatrics, and neonates, they have different outcomes, with the best outcomes in the neonatal pulmonary team. So our center stands within South Asia, West Asia, ECMO. That is, we are the SARC countries, plus Middle East. In 2015, we were asked to take over Africa also as one of the beneficiaries from us. So Africa also became entire Africa. They are with us in the SWAC chapters. Before we had the logo you're seeing to the left side with green and blue, and after 2015, once Africa became a chapter, then our logo has changed. We cater for a population of 2.56 billion. So some people might argue that we don't need ECMO. Certainly, you cannot say that a population of 2.56 billion don't need ECMO. We are the believers and we would like to go ahead in the way we trust. ECMO Society of India was established in 2010 with great ideals of spreading, uh, teaching the science of ECMO and promoting ECMO. It was started at Riddhivinayak Hospital and center remains as Riddhivinayak Hospital to date. We have been conducting conferences, training programs, national work conferences as well, ECMO workshops, and ECMO fellowship program. You can learn more about us by going through the website. So the cost of life is very difficult to define, and so we would like to continue in supporting life with ECMO whenever it is needed. So the take-home message is we briefly dealt with the history of development of ECMO and the landmark trials in documenting the efficacy of ECMO, what is ELSO, ELSO statistics, and the SWAC ELSO, ECMO Society of India as well. Thank you very much. And if you have any questions, I'm happy